My name is Dr. Marlon Rollins. I've been in the behavioral self space as an executive and as a provider for some 20 plus years, originally from Indiana. I started my career and had my master's degree. I was actually a school counselor for gifted and talented students, where my job was to assess every patient or every student who came through the school for suicide risk because there had been suicides that happened in that school. So that was the beginning of my career when it came to official career, and then worked on college campuses. Following that, I worked in the emergency room doing face-to-face assessments. I worked doing med bed consults with a local community mental health center. And from there, I became a director of a crisis center, a psychiatric hospital. I actually worked in the prison for a short period of time as a psychologist. And yeah, but I moved into the hospital sector primarily, and I ran a crisis department for about 6 years in Indianapolis, Indiana, seeing about 30 patients a day, 120 bed unit, everything from youth to geriatric services. And then I moved out to California back in 2016, where I was a chief operating officer of some of the largest psychiatric hospitals in California, from the Bay Area to Sacramento. And then I got into the addictions detox space in 2019, where I was a COO and chief operating officer and have worked in Orange County, Los Angeles. So my role has been something around suicide. Lacey Thompson, I see your name. I see it. So again, anyways, I've had a wide scope of different agencies, and I just appreciate the gravity of what everybody does into each one of these facilities. There's always something that you can tailor specific to like how you want to improve suicide prevention. And I also see clients now as a private practice, and I'm currently the chief clinical officer for Hollywood Detox, located in Los Angeles, California, where it is a rehab center where we both do outpatient and inpatient services. And some of the things that I'm going to share with you today have been integrated into our programs. So we get into the topic today. Again, that's a professional background, so you know who's talking with you. I've also been on the steering committee for suicide prevention, and have been on the board for United Survivors, and I serve on another board for suicide law survivors called Morning Glory. But again, I am going to say that this is a content advisory because I've done everything training from suicide prevention to self-harm really extensively. So I want to be honest with the clinicians that are here, but do mindful, take care of yourself. We also have a tendency for a lot of burnout in this space as being caretakers for other people. You guys are on the front lines, so there's a lot of secondary trauma that goes on. So my contact number is there, or excuse me, my email. So feel free to write that down if you want additional support or have training inquiries. We'll do some follow-up with this group. Again, my hope is to provoke you to action and to help enhance what you're doing in your clinical practice and maybe take back to your leadership. So we're going to be talking about these three elements, not just prevention, but intervention and postvention when it comes to suicide, because these all work dynamically together. They're all important when it comes to improving our treatment systems. And it's National Suicide Prevention Month. So again, for me, this is more of a call to action to do more in this space, because it doesn't seem like we're doing enough effectively. We've done a lot of great things, but maybe we're not doing enough. And one of the things that I've seen as a clinician over the years is just not getting enough training. Yeah, competing Wi-Fi. Oh, okay, I'm coming in and out, somebody said. All right. Oh, I don't want to have that clutter. Give me 1 second. I'm going to turn off any other Wi-Fi. I want to make sure you guys can hear me clearly. Awesome. Okay. Again, as I was saying, is a lot of times we just don't get a lot of training around suicide prevention. It's the one thing that we can be even afraid to have a conversation about. It's the one thing we don't want to have happen in our practice or our hospitals. So I want to just acknowledge that it's uncomfortable. And again, a lot of the training that we typically have as a clinician, if you can maybe put in a chat, like how many years did you get training specifically on suicide? Maybe it was just a semester, maybe it was just a couple of weeks, maybe you've had none that were officially, maybe it was a book chapter. How much training have you had in your practice? Can you throw that in the chat for me? Like how many years, or just maybe a few months or a week? Yearly. Good. Okay, you got an annual training going on, Lori. Thank you. Second training with you prior to be with you. Oh yeah, great, Michael. Good to see you. Yeah, private practice once a year. Okay. Yeah, and so we get some information, but I also want to give you some tactics on what to do. And one of the things that I share with people, because it's one of the things that I've done in research, is always given like a reflexology statement. And that means this is not just a clinical thing, but this is personal work for me as well. So I want folks too to understand that that I've lost my sister Amber Rose. This is my sister Amber Rose Rollins. I lost my sister. She was a nurse. You can see her right there in the middle. That was actually taken in 2012 when I was working in the hospital. We worked in the same hospital agency. She was a transitional care unit, and I was a crisis worker in the emergency room and in the outpatient clinic where I took calls and did intakes and all of the things that you do in a crisis department. So her and I were always close. There's pictures of us growing up together. She was 2 years older than me, and we always had this dream of us working together as providers, helping people. And really, she was passionate about being a nurse. She had a daughter there too on the other side of the screen. Her name is Khadijah. So I took the little picture up in the corner. We were at holidays, but in 2013, my sister ended her life, and it was an enormous tragedy within the family, specifically for me, going through the feelings of guilt and being a clinician who was working in the space. I was a director of a crisis department at the time. So she went through, struggled with an addiction, the shame of that. Her license was suspended as a nurse because of her substance use. She was going through a really terrible time with a divorce, and she couldn't seem to get her life back the way she wanted to be. And she ended her tragically firearm again. And a lot of people were like stunned because you can see my sister smiles in every picture. There's not a picture that she doesn't smile in. And for her to be, she was 37 years old and she ended her life again with a firearm. And her daughter, Khadijah, there on the left, or maybe you're right, was a witness to it. She was the first person to find her in the home. So it was absolutely devastating for our family, as you can imagine, and it just has created a ripple effect. So for me, that happened in 2013. I went through a lot of, gosh, counseling myself, therapy myself, getting involved, trying to figure out what to do. And I couldn't escape the work, essentially. I couldn't find a way away from dealing with the suicide because every day I was dealing with people who were suicidal and I was working in a hospital surrounded by nurses. And I just felt that pinch against the wall. And instead of, because I couldn't really retreat, I decided to face it head on. And I started working with the Zero Suicide Initiative and within the healthcare system, which was a 5,000 employee, 7 hospital system in Indianapolis to integrate suicide prevention protocol. And I realized that by telling her story, I could engage more with people. And also, it gave me more purpose. So as I do these trainings, I always think about her coming along with me to help give her voice to help other people. So I honor her and thank you for your condolences. So again, I share that with you because this is a personal story and training just as much as it is a professional kind of clinical for you to get your CEUs. So one of the things I want to announce too is my niece, my sister's daughter, she had a daughter who's named after my sister. Her name is Amelia Rose. She will be 2 years old on October the 11th. My sister died in 2013 on December 31st for the exact date. And obviously, we've all missed her dearly. My niece had gone through her own crisis and struggle after witnessing something like that, the traumatic event. I've had to hospitalize my niece, for suicidal ideation following the death of her mother on at least 2 occasions. But I'm very close to her now. I'm a watchman for her. But she had a daughter, beautiful daughter named Amelia Rose, who just suddenly came around the same time that my sister's birthday was. It was an absolute blessing for her to have a child, and it gave her life more purpose, as you can imagine, and learning how to love in spite of this tragedy. The other thing that has been more of a recent impact that I'm just now sharing is Amelia's father, Estefan Rodriguez, 25-year-old. He ended his life just this year on June 8th. So again, this is a second devastating suicidal loss, also with a firearm. Now, this young man was with my niece since the age of 19, and they had a child together just 2 years ago, but he killed himself also with a firearm. And right before, if you notice, June 8th, this is the week prior to Father's Day. So this young girl, Amelia Rose, will now have lost both her grandmother and her father to suicide and will not have those parents, and has a mother who is obviously very traumatized by the losing both her partner and her mother. So prayers for my niece and for this little girl. Again, this is a very sensitive topic, a very emotional one. So it's a call for me. So what about this to think about this young girl who embodies the essence of my sister? In fact, my sister was known for always sanitizing her hands because she carried hand sanitizer all the time. And it just so happens Amelia loves to sanitize her hands, like just asks for it and rubs it in like a little lotion. So it's just an endearing message of her continued life, but now to lose her father by the same means. Now, I will say this, paying attention to, thank you, Carmen, for your remark there. So paying attention to also the institution, construction workers, I'll just say this. He worked in construction and he was a young man who construction in particular has the second highest rate, or actually this highest rate of suicides as an industry. So it's important to pay attention to him. My sister as a nurse, even though she was a woman, women typically don't kill themselves by fire, but she's also a nurse and providers have a higher risk. So that exposure of the jobs that we have also can add to our risk. Okay, especially when it comes to helping other people and not getting access to treatment. So I share with you the devastation so you can understand what I'm talking about, why I'm talking about, the way that I'm talking about it, and where it's coming from. And let me just ask this group, how many of you have lost someone, a patient or a family member to suicide? If you are comfortable sharing that please, because I want to honor everyone that is a loss survivor here, whether you're a clinical loss survivor or a family loss survivor. Thank you for your prayers. Okay. Thank you, Kareem. Yeah. Two patients. Yeah. Three patients. Lost multiple patients, clients, family workers, co-workers, family loss. One. Okay. Yeah. And my heart goes out to you because it's incredibly impactful. So again, I just want to acknowledge that. And this, let me ask second question too. How many of you lost someone to a firearm? Yeah. None. Karma says, but I have a very acute. Yeah. Two. Family member to a firearm. Okay. So again, not in New Zealand, this would be rare. And this is important for New Zealand, and I'm glad you're here too, because this is also unique to the United States in some regards, because I've done some work internationally, and that access to lethal means in the US by firearm is one of the most common ways that you'll die by suicide. Again, you could still have utility here. I'm not saying that we're not going to talk about other lethal means. There's actually going to be a model, the clinical model I'm going to give to you. Yeah, one of my clients committed suicide by firearm. And for those that die by suicide. So again, this is dedicated to all of you and to those who are lost survivors and attempt survivors. I'm also going to acknowledge that presence that could be on this call. So let me just set the stage. And again, I'm sorry, New Zealand, I'm going to focus on US a little bit. However, this absolutely applies when it comes to the dynamic clinical part of it too. And if you could tell why in New Zealand that firearm deaths by suicide are more rare. So thank you. In the US, this is data from the American Foundation of Suicide Prevention and the CDC. It's the 11th leading cause of death in the US. Okay. Now, the 11th leading cause of death, if we stratify those numbers a little bit differently, you're going to see some different outcomes. Meaning, so that's about 5 to 6 suicides per hour. So and this is US, in every 11 minutes, somebody dies by suicide. And in other presentations I've done before, yeah, so Pamela said very tight gun laws. In other presentations that I've done before, I've noted that years back that every 11 minutes, it used to be like every 14 minutes, every 12 minutes. Actually, in 2020, we had one of the lowest rates of suicide, but it jumped back in 2021. So right now we're estimating in 2023, because again, this all data lags, we're at 49,000 suicides, which coincides with 1.5 million attempts. So for every 30 attempts, for every suicide, there's about 30 attempts in the US. We're on track right now to be projected higher rate, about 50,000 suicides already for the year of 2025. And I note here too that for every one suicide death, approximately 6 individuals are directly impacted. They're close. Yeah, somebody who comes Laura needs better regulations. And so that's part of this conversation I'm going to have with you today. And I'm hoping you can spread the word and we can talk about why that is specifically in the US, because there's things that we can do. And when it comes to developed nations, suicide rates are one of the highest of one of the developed nations. I think we're in the top 3 to 4 to have this such high rate of suicide. So you've probably seen these stats before that men die 3 to 8 times more. White males in particular have the highest rate accounting for suicide deaths in 2023. And this applies more specifically to older white males. Again, and there's a notion of the idea of suicide is and mental health is changing in the US. Again, I pull out a stat that says that 91% of people now, this is 2024, feel that mental health is perceived as equal or more important to physical health versus in 2018, where 80% of people perceive mental health as equal to physical health. So it is, and if you're in the media, we're definitely talking about it more on social media. So there's a change in people's perception of saying, oh, your mental health is not just important or equal, it's actually more important. Your mental health is that much more important. However, we're still seeing these numbers increase. And I remember when my sister died by suicide and I was pulled into more of a kind of call to action, I wanted to see there was a goal that was set that they would reduce suicides by 20% by the year, I think it was 2020 at the time. That didn't happen. We went in the opposite direction. We've seen increases in suicides year after year. And again, I'll note here, firearms account for 55 plus percent of all suicides in the US. And so this is an age adjusted CDC, because when we talk about the 11th leading cause of death of all causative of all ages, that changes when we scope down when we're just talking about those that are younger between what ages of 1 to 44 or just 10 to 44. You can solidify down to there. You'll notice that it is the second leading cause of death in the US. So that blue bar, and you'll notice it even higher than more common than homicides, that suicides are the most common second leading cause of death. The only thing that leads that is accidental deaths and injuries. And this would include overdoses. This would include any kind of accident, any type of accidental overdose or car crash. So then suicide becomes that green bar becomes the second leading cause of death. And then again, I'm going to underscore that more than half of those were related to a firearm. And this has changed. If you notice, if you can try to drill down a little bit more, if you notice the changes in the other disease course, people dying, like HIV in 2013, if I were to go back, you would see that was a much higher leading cause of death. But because there's been investment in HIV treatment, you don't even see in 2023 that there are no deaths on this particular report where HIV is caused. But if you were to back up and go back into year 2000, you would see a much higher number. I were to go to 20, see a lot more COVID cases or causes of death. Interesting to see the evolution. Yeah, it says worldwide. Oh my goodness. I'm getting some signals that says my internet connection is unstable. That's unusual. Again, I apologize for that. Again, thank you for your comment. Yeah, poisoning is number 2. Firearms is number 1. You're absolutely right. Poisoning in other countries like agricultural countries, South America in particular, it's poisoning. So this is the data that I want to share with you regarding age in particular. As individuals age, you'll notice this blue line here at the top, that's males. And if you notice at the age of 70 in the 70s, 75, that death rate goes up substantially, specifically for older males. Females, you actually see it decline. So again, I'm just asking you to notice the trends here. And then this is a general kind of number. So again, this is just by gender. The next one I'm going to give you is by ethnicity, and specifically whites, Pacific Islanders, and this is Native Americans are substantially disproportionately having more suicide rates. Males, again, outweighing females. I'll also call to attention here that if you notice that Black females have one of the lower rates of suicides than any other per every 100,000 than any other group here. And that's an important thing to talk about. And we're also going to look a little bit about what's been changing in these populations. So these are trends, more information for you. So here's some trend data. White males, again, this is 10 years trend of suicide rates back from 2014 until now. We've seen some general increase or just a slight increase within white males. This red line is American Indian males, and we also saw that peak up in 2021. This mauve line at Black males, this has been a conversation that has come up a bit more, that we're seeing more Black men since 2020 having an increased rate of suicides. Again, I'll call out this very bottom line here because this is Black females. And you'll notice that it's been one of the lowest groups to die by suicide, but we've seen a slight increase in the last couple of years. Again, there's some research that has been published about what is the protective factors around Black females. Historically, this is before that we've seen the slight increase, but it was because of what specifically older Black females have one of the lowest suicide rates, and it's being attributed to who they represent in the community. They're very tied to culturally supporting the family as mothers and grandmothers and great grandmothers, the spirituality and their beliefs about ending one's life. They don't carry that belief as that's not an option. So their ideas about suicide, the cultural identity that they carry has created a protective factor within that. So the idea is what can we learn from that group, all right, as well. So those are some elements that I think are important that their attachment to their community and their connection has been very meaningful. And maybe there's an argument that's starting to dwindle a little bit within that group, which would be a shame. But I want to call that out as that has been identified in the research as a real protective factor. The Again, this was mentioned in the group chat here. Yeah, worldwide hanging is number one. Think about what's easiest access, poisoning. But in the US, we have this terrible dearth of, okay, 55% of suicides are related to firearms. So again, if we're talking about how do we reduce this number, what do we do something about it? A lot of the answer does lie into access to lethal means. And what can we do to intervene? If I had more time, I would go to you specific kind of national interventions. If you are interested, please email me. I can send you articles about what other countries have done, like in Japan, to help reduce access to other lethal means, like with access to trains, etc. So any intervention that limits the access to the individual to a lethal mean can help save the life. And sometimes I've argued, and it's easier to get access to a firearm than it is to get access to help. And that's where we see this imbalance. So if that's one statement you can take away is like, how do I make access easier to people and limit and reduce access to lethal means? That disparity that we have specifically in the US, if you ever try to make a therapy appointment, it can be very difficult. Renee dropped in the chat the access to firearms screen form. So I want you to capture that. Renee will drop it a few more times and even more at the end of this conversation today, because I want to make sure that we're using that tool. So the other thing that I want to point out, again, this is a United States issue, but if you've watched the news, is this conversation about mass shootings. So again, we talk about mass shootings, but I've noticed in the news, we don't really talk about the suicidal part of the mass shooter or the shooter themselves. So again, that data that says total suicides, the same numbers I gave you before, there's a trend of increasing suicide firearm rates from 2012 to 2022 by up more than 20%. Okay. And then the trend over time when it comes to mass shooters who attempt by suicide or who mass shooters, and we know every mass shooter obviously involves a firearm. That's 100% of the cases. But 30 to 40% of them overall will have some type of suicidal intent with that, meaning that at the end of this gun shooting, that they know that they will be killed or that they kill themselves. And this has happened just in the last 2 months of some of the mass shootings you've seen on TV, is that there's been a suicidal component. There's also data that says when it becomes to somebody who's younger, below the age of 25, this even includes high school, 60% of the mass shooters involve some type of suicidal crisis. So this is not just die by suicide, but the suicidal individual is also a detriment to the community, which we keep talking about, and nothing seems to be happening when it comes to additional gun regulation. So again, suicidal thinking is often related to mass shooting. Again, with 72% expressing some type of ideation prior to or during the event because they know. Exactly. Perspective is always an issue as well. When we make a hero out of Thelma and Louise for taking their lives, it's much more wonder. So again, you're right. So when we idealize this sense of or glorize or glamorize the idea of suicide, and sometimes that might be the intent, which is why we don't have these discussions about lethal means in particular, or we talk about the individual too much. It sounds like, oh, this is the way that I want to go. Again, And it's can be very culturally bound. Like in some Asian communities in Japan, the idea of dying by suicide is somehow honorable. When you if you talk to Black communities and specifically older Black men, that's not the case. Oh no, you're not doing that. You're going to hell. That's the idea of, oh, never end your life. Or what are those judgment places? And I'm not saying that going to hell is a protective factor. It's just your beliefs and ideas about what it means to die by suicide. So those are important things to talk to clients about, or talk to your patient, or talk to your friend about their ideas about what that means. And I'm going to give you another model to go from that. Let's talk about intervention. Again, that's all the data stuff that I think, again, gives us some bandwidth, because I like to be data driven when it comes to strategies. And every state might be a little different, including every country might have a variant. And you need to really understand what are the factors going on within that community that are going to contribute to higher suicide risks. So I intervene with care. So everything here is really prevention. But we want to figure out, how do we really intervene with care and consideration when we do have a client who is higher risk for suicide? And this includes identifying the warning signs. I'm going to introduce to you a new concept called the death wish, okay, as a way to look at suicide prevention. And I'm going to go over the assessing for suicidal ideation. Just throw a yes in the in the comments if you have been trained extensively on ideation, plan, and intent. So yes, if you have, just throw that in there. So we've been talking about, are they have ideation, do they have plan and intent? So everybody's heard that before. Yeah. Yes. Yeah. If you don't think it's good enough, say it's not good enough. I need more. I need more than that, because we've heard that a lot. And then we rolled out, if and people who use right, yeah, it's not good enough. If you use the Columbia, write CSSRS in the chat if you're using the Columbia already. Do you use it? CSSRS. Okay, great. That rolled out a number of years ago through the Joint Commission, because we've seen these rates go up. And again, so we want to build onto that. CSSRS is looking at intensity, frequency, and ideation. Columbia daily, good. That's best practice, is to use it daily with every patient. Since last visit, there's a version called SLV that you want to use consistently with clients every encounter. Safety planning versus the new suicide contract. Is anybody using? I won't put you on blast. I'll just say the idea, and I found this when I moved to California from Indiana, that I was working with some institution. They were still doing safety contracts. Actually, I was working in a psychiatric hospital. I won't say the name of it, but I was like, what are we doing just having inpatient clients sign safety contracts? I mean, I won't kill myself. That's not helping. So the idea of, if you're doing that, please don't do that. Use safety planning. I'm going to give you an example of a safety plan, and you can look it up too. I don't have a direct link to this one, but it's available on free form. So intervention. So one of the things I think is most important is, first and foremost, enhancing our detection of, like, warning sign. What is our warning sign detection? Because you can look at high risk and warning signs, but I created a model that I use in practice because I felt like what I was getting was inadequate. So I was taught on this version called SAD persons. Has anybody heard of, if you've heard of SAD or used SAD, just write SAD in the comments. Has anybody used that tool? SAD? SAD persons was an acronym. And again, and imagine that I'm in the emergency room. So I would see a patient that's coming in, and he is a 50-year-old male, and I need to make a decision of whether he's going to go into, whether I'm going to admit him into the psych hospital or not. And what I found, and it would rank on a score of 10. So if you got a score of 10 or higher, then I was going to more likely admit you into the hospital. But what I found was that if I had a Black woman, okay, who may be struggling. I'll take my sister, for instance, who may be really all the score enough just because the tool is biased, meaning that if I give her a 1 for sex on being a male, then okay, she gets a +1. If she's above the age of 44, then she gets a plus, or she has to be younger than 19. She's not, she's 37. So I don't score her on that either. She's had no other attempt ever. She's not using alcohol. Okay. She's a rational thinker. Okay. She has some social support, right? There was no organized plan. And she was going through a divorce, so I guess I would score a no spouse, but she wasn't sick. So that was a problem, right, for me. It was like, so if I were to use this as a screening tool, if I were to talk to someone, I'm going to miss a lot of things because it's a biased instrument. Now, maybe it can be helpful when you're recognizing that, yes, age and sex do play a role, but what it's not missing is some of the more constructual things about mood state and behavior. So I created my own acronym called Death Wish, which I will share with you in the chat. You can drop that one again, Death Wish. And it is a more memorable tool, and I'm going to go through it with you today about how to use it. Now, I will tell you, it's not clinically validated, but for me and for other clinicians or even in the community, they're like, what are the warning signs? Because people always ask this question. So I never forgot Death Wish. Death Wish reminded me to ask clients, are you thinking about wanting to end your life? When I saw the following things. So Death Wish was a set, the death stands for a set of mood states. And Renee, if you want to drop the Death Wish PDF now for folks to pull up, you can download that from the chat. The mood state. So depressed mood and looking at using PHQ-9 if you're a clinician, but just seeing the person, that depression of not wanting to eat, they're isolated, that kind of stuff. And it usually comes through. And I know we talk about depression as being like the leading cause of suicide. I would make a case to argue that it's actually a manifestation of a lot more anxiety, meaning that there's a lot of fear and sometimes ongoing fear can lead to prompt to someone. Some people who are so depressed, like clinically depressed, are so depressed that they're not even motivated enough to do anything to die by suicide. It's just exhausted when they don't feel like they're getting any kind of treatment. So that major depressive symptom, yes, but the day-to-day depression usually comes out of a form of a lot of anxiety, a lot of pressure, a lot of fear, being overwhelmed, feeling trapped. And this is where these other elements so come into play. So when I think about depression, or excuse me, death wish, the mood states are depressed mood, okay? Elevated mood, meaning like they're agitated, they might be maybe extreme mood swings. Okay, think about the mood state of dealing with the idea of am I going to kill myself or not? So they may be really quiet, they may be angry, they might vacillate a lot of time, a lot of agitation. So this brings in more of the elevated or more agitation state of suicide risk. A lot of anger and defensiveness, anything with agitation, anger, anxiety, aggression. So that's the A. These are mood states. Feeling trapped. I mean, I don't feel like I can get out of this. So this feeling that they had of I'm helpless. And then the H, meaning hopefulness, meaning like it will not get better. Right. So when you combine these mood states that person is in, they're angry, they're feeling trapped, there's hopelessness, there's depressed mood, or whatever situationally that they're going through. And if there's a precipitant like a breakup or whatever it is that they're going through, a job loss, something they're really ashamed of, this is the same thing. And this is where I believe that when we talk about high risk patients who are discharged from the hospital, psychiatric hospitals, there's a higher risk within that 7 day period. Like you don't feel good coming out of a psychiatric hospital typically. You might feel a lot of these things instead. It's not, oh boy, that was great. I got out of the hospital. Everything's no, you go back into the situation you were in and with feeling like you were trapped and not sure how you're going to be treated and perceived post discharge. So there's been pressure, obviously, to have a follow-up appointment, if not the next day, at least within the week. So best practice is to close that gap. But this is the thing, like not everybody has this encounter with the psychiatric hospitals. So if you're seeing these mood states, and the other thing is the behaviors. So death is the mood states in the acronym. Behaviors are they're withdrawing. So if you observe these things in your clients, in the community with a friend or a family member, withdrawing, isolating away from others, talking about death, man, it'd probably be better if I wasn't here. Stuff like that, that passive dialogue, those are behaviors that clients will have that are indicators of what are their thoughts around suicide. And they're talking like, man, I just wish I wasn't here. I wish I didn't have to wake up in the morning. I don't want to do this again. Those are the things that are behavioral indicators. Substance use, increased use or desire to use drugs. Okay, so these are obviously if you're dealing with a lot of emotions, specifically anxiety, there's a tendency to use more alcohol, there's a tendency to use more marijuana. or maybe other substances to help cope with the discomfort. So that's a behavior. Somebody's drinking more or smoking more. That's a good indicator that they might be thinking about wanting to end their life. History of attempts, obviously, if somebody's had it in the past or they've done something, that's a behavior. So if you've seen it in the past, you're seeing these mood states, you're seeing these behaviors, prompt yourself. Do you have thoughts of wanting to end your life? Do you have a death wish? And so I use these as a training tool to help people look at death wish, remember this acronym, and see if you can indicate even a few of these things to prompt someone to say, you know what, let me just ask this question. And also it leads very well into asking a question, do you have access to a firearm? Because we talk about plan, but again, we have to recognize that tends to be the most common lethal mean. So we have to ask this question, especially if we're in the US, do you have access to a firearm? And I'm going to give you the firearm screening too. Here's a case example of how to put this together. And this is a model that I use. You can pull this off of SAMHSA's website. It's called Tip 50, how suicidal thoughts and behaviors in a substance abuse treatment. And again, this hospital that did not have a suicide prevention program. Okay. Renee, can you drop the firearm questionnaire and can you drop the death wish screening form in the chat for the group, please? I want to make sure everybody gets those. Okay, thank you so much. So download those, save them. Okay, I want you to use them and the death wish, which is a handout you can pass around, put it on your desk, hand it out to people. Again, I am not, my goal here is a personal mission. I don't want to see more people die by suicide, and I don't feel like enough is being done. So this is why I'm compelled to do this presentation and to just give you these resources so that you can use them. So please use them because I feel like there are gaps in the resources and the training that myself as a clinician has had, and my goal is to fill those holes. So again, here's an example of, okay, 30, John is a 34-year, yeah, Renee mentioned they're on your student area. So if you have questions about the slides, you can follow up with me and I'll try to get them, because again, I have a lot of personal stuff in there too. I try to pull out the things that are going to be the most grabbing. Anything else that I'm sharing with you is available on American Foundation of Suicide Prevention. We can maybe pull off the resources and you can take a look at it if you want the research side of it. And I'm going to give you some website links too that you can go to for more information. So look at this case example. So we're talking about John is a 34-year-old. John is a 34-year-old white male distancing from friends, drinking every night, helping night to help with sleep. He's separated from his girl 2 months ago. He laughs about being better not here. He brushes it off as he's just joking. He spends more time alone. He's working part-time a job he doesn't believe. He's been in a rehab programs in the past for an alcohol in the past, but states it didn't really work. Now, okay, he's having a hard time. He's going through some stuff. He's drinking. Now, if I were, because he's a white male, okay, you could be very biased and say, oh, white males are more likely to end their life. And that might prompt you to get more interested about his case. But that alone is really not enough. And in fact, if I were to switch that out and say, okay, he's a white female or a black female, you might look at it and go, oh, black women don't kill themselves, even though the clinical itself might be the exact same, or a black male, right? So that's where I get really cautious about this notion of biasing certain groups, because then you're not asking certain questions based on somebody's gender or race. I think it's important to recognize that there are disparities, but there's also disparities in getting access to help. That's a whole different conversation to have, but it just generalizes into healthcare. But I want you to be aware. Now, if I were to add in this conversation, just one question to all your clinicians, all your programs, does John have access to a firearm? Now, if you have not asked this question, you have not fully assessed the risk of what's going on with your client. In the chat, that site's mentioned. Yeah, find the info. Yeah, yeah. I'll have the links of all the information that I have. It's on the reference page here. So does John have access to a firearm? That's a question that's going to tell you one way or the other, oh my gosh, yeah. If he does, I'm going to act different, right? If I tell you that John has a gun, then you're more likely to take that more seriously. If I don't ask that question, which is very common, then I'm going to miss some things. I could use bias might shift me out of taking additional actions, access. So again, I want to underscore how important it is to ask about firearms. So that tool, if you don't do anything, I encourage you as a clinician, as a peer support, or whomever you are, is to ask those questions about firearm and is it safe? Because firearms are the leading cause of suicide. The mortality rate if is between 80 to 90% of firearm suicide attempts end in death. So it's important for us, and that's one of the things that I've recognized that not today, I'm not able to make substantial change in the policy, but what I can do is ask every client that I have about firearm access, not just for the individual, but also for other people in that individual's home. Because I have seen clients who have, and maybe you have too, who have gotten access to a parent's weapon unknowing, and the guilt that's left with those parents because their son or daughter got a hold of a gun that they were responsible for and they didn't have proper access to gun. Now, there's another link. I think I sent you a link, Renee, on firearms. Can you find that? It's from the American Foundation of Suicide Prevention. And there you're going to find a lot more resources and information about gun safety and safe storage, etc. And I want to make sure the group looks at that and finds local resources related to your state around making sure that there's gun safety. If you can't find it, let me know and I'll see if I can drop out of this and send it back. So this is a model that a person would go through. I used to use is path warm, but it was corny. The but I wanted to walk people through like the decision tree. I would yeah, you can report about the Safe Reporting Act. That's going to be on that website. So I want people to definitely go into that reference. But yeah, you can safely report someone without having any, like just gun safety. IDs, you're voluntarily giving that gun to, it could be local law enforcement for safe storage for a period of time. Those are the kind of things and programs that are in place by different states and find out what those are. So when somebody says, yes, I have a gun and it's not safe, then we should know exactly what steps we can take to make sure that weapon is stored for a certain period of time. Things like a 5150 in California, which is like a immediate detention or emergency detention that we'd have in other states, that also prevents somebody from actually getting a gun for a certain period of time. 5 years for the 5150. And if somebody gets two 5150s in a year, then that's a lifetime ban from gun access. But we know that just because you can't go buy one doesn't mean you can't get access to one because they may have one before they have had an encounter with a psychiatric hospital. So again, this is a model to help people make decisions. If they said yes, we contact their supervisor, they take action. You may have to discharge someone out into a higher level of care. This one is designed for a treatment center, which is not a non-acute setting. And this is also, let's see, confused. He's asked twice to drop in the chat for us. Okay, okay. Yeah. Yeah, Renee, see if you can get that in there. I want to make sure people are getting, if you can't find it, just shoot me a text and I'll try to go back and drop it in. So yeah, these are some important tools I want to make sure everybody has. You can see. Okay. Try to get. Yeah, if I can't, yeah, just stand by. If she can't find it for me, I'm going to drop it in at the end of this. Make sure I'm on time here. Okay. All right. So
I
I've
can't.
got some. You can't find it? It's at the top of our conversation. Let's see here. I'm going to repost it. Select all. Oops. And then I'm going to give you another full training. I'm going to give you another training that you guys can do for free. Okay, that's available that even digs deeper into counseling on access to lethal means. If you haven't taken that, I encourage everyone to do it. So if you're using a Columbia, this is what it looks like. Have you had an attempt to harm yourself? And this is what they would fill out if you haven't seen one of these forms before. But usually this is a clinician that is doing this form. Individuals saying, yeah, I took pills back in 2024, punching the walls. Again, and one of the things that I want to call about the CSSRS, again, I love it. It's a great tool, but it doesn't explicitly ask about, do you have access to a gun? You'll notice here in question on number 8, it says making attempts towards preparing to kill yourself, collecting pills, obtaining a gun, giving away valuables, writing a note. And it writes generally yes. And then it says wrote a note, but it doesn't, again, explicitly say, do you have access to a firearm? And I think that needs to be called out. And I don't know why we're not asking that question more explicitly. Now, there are programs. Ours is one of those that we require every patient that comes in, we ask them, do they have access to a firearm? And I know, and I've worked with some 988 operators that they've told me that, yes, they're supposed to ask every caller, but some supervisors say do it and some don't. So I will make this a personal issue because I've been personally impacted that in my practice and institutions that I work with, everybody gets asked this question around firearm. It's the one thing that we can do. Yeah, no worries, Renee, on the internet. That does happen. The other thing that I want to give you too, and I'm sorry I don't have a link to this directly, but this is in the intervention side. Okay, good, good. Michael said that the CSSR has access to firearms question on it. That's great. If it doesn't, as long as you're asking about it, you're in a better space. But if you look at the form that I gave you, it builds in that too. So one of the things that I'll say about the CSSRS is that some people, clinicians in particular, it's very exhausted. It's cumbersome and clunky a little bit because I remember implementing this in different institutions. Oh man, I got to do all this. And I said, yes, it's important for us to do because it was a validated tool, but it doesn't pronounce out firearms. And I think if we're going to really say that, oh yeah, lethal means firearms is a big deal, we need to push firearms out there as a clinic or within the community as a peer. Do you have access to a firearm? Where is it? Okay. Again, yeah, that link that I gave you will give you more information about the SAFE Act and other policies and procedures that are supported in different states to help reduce access to lethal means. But as a healthcare provider, I believe it's our responsibility to integrate that into our practice and not leave it to other systems. Everybody has now learned how to use the PHQ-9. We'll have access to all the recording and the chat for all of the great resources. What I'll try to do is also send these resources specifically out. And if there's something that I can do to modify the presentation to make it simpler, because it's a big file, I'll send that out as well. Let's see here. The collaborative safety plan, let me just go back there. Who uses the Stanley Brown safety plan? Can you just put Stanley in the chat? Because I want to make sure folks are familiar with it. Now, mind you, it's putting warning signs in place. The idea of a collaborative of safety plan is that you're doing it with the client, right? You're talking to them and you're developing it. What are the warning signs for that individual so that they're aware and you're aware? So for those that said, yeah, I got a client who's, shoot, Renee, I'm cutting out to everyone. Can you guys hear me? If you just hit okay, if you guys hear me okay. And Renee, I don't know if it's you or if it's me, if I'm having a problem. Okay, I think I'm okay, Renee. It might be your internet signal. That I'm cutting it out. I did have one glitch of actually I got an alert on my computer. Okay, well-being. Good. Well-being is a health system. Yeah. Hmm. Okay. I just got an alert that my internet was cutting in and out too. Again, so I'll try to pause and go back to stuff. Again, I apologize for that. So yeah, Stanley Brown is one you can use as long as you have one that's collaborative. That's really the key. And specifically when you're getting in, okay, making the environment safe. Again, gun safety plays a role. Listing out those who are those helpful people. Never be the only person that's involved in the suicide prevention plan. Try to have the other individual, have a friend, have a family member saying, hey, who else can we talk about this struggle that you're going through? And then have that dialogue. It should be listed here. If you can, ask permission with your clients. Let's have a conversation with them because I'm just concerned about you that you're going to be okay. And have them follow up because you want to have 3 or 4 people. I don't know how many times, even as a clinician, we feel fully responsible. And especially for those clinicians who have maybe lost a client, sometimes you feel fully responsible for the death of that client and wish you would have done more. And we have to recognize that our own limits. But if you've lost someone, like I've lost someone, think about what else could you do? Not blaming yourself, but what action can you take? What would you improve? What would you do differently? It becomes an exercise of how do we get better because that's how good suicide prevention works. So I want to give you a case conceptualization of suicidality that's beyond the ideation and intent. So this is a good framework if you're thinking about suicide or if you're trying to assess a client for suicide and you've got the warning signs in place. And this is some work that I've done with another researcher and trying to understand suicide better in a crisis. So there's three key factors that are going on. Yes, I do consider the therapeutic relationship as a protective factor. Yes, I do. And I use it. I'll tell my clients that I'm concerned about them if they're suicidal. And I'll talk to them about our relationship and what it would mean to us if I'm concerned about that. And it means a lot to them. So these three constructs that I think are really important. One is, does the individual have a sad appraisal? Meaning a sad appraisal about the situation, what they're going through, right? Looking towards the negative. They have negative feelings and they have a sad appraisal about what's going on with them. So stressful life events happen. We all have adversity in life. We all go through stuff. So the interpretation of that individual, are they always looking at it as on the bad side? And the other element of level of resiliency, and I've written a whole book on resiliency because I think that's the number one protective factor outside of access to lethal means, but actually developing resilience and knowing how to get through adversity. If they have a low level of resilience, and this also involves protective factors, okay, when you do have strong supports like a therapeutic relationship, you have access to resources, you have good coping skills, those kind of things. Like, how do I bounce back through adversity? What are my resources? So if they have very low level of resiliency as a clinician, you want to build those elements up. And so the book that I wrote that I'm not going to just bandishly report is talks about these five, actually particularly four growth codes to help with developing resiliency. And again, just having a sad appraisal alone does not mean that someone is going to be suicidal, but it is that does play a part of suicidality. The next element that's important from the psychological assessment is the level of moral consciousness. And this gets into the cultural elements of their thoughts about their responsibility to others. So the internal awareness of doing good, meaning I don't want to hurt someone else. I wouldn't do it because I don't want to hurt my kids. I don't think it's the right thing. I don't know. I don't want to hurt God as a higher power or whatever that is, that an internal awareness of just being a good doer. So if that's lacking, if they're saying they're apathetic, I don't care about you, I don't care about myself, I don't care about anyone else, my life doesn't really matter. It's not that big of a deal. In fact, I'm a burden to other people, which gets into that sad appraisal kind of mentality. It's better off that I'm not here. And the level of risk taking. And this is important for we're dealing with clients specifically who use maybe more addictive substances where they have high risk jobs like law enforcement, first responders. They tend to be higher risk takers and more exposure to death. So the moral conscious, yeah, they might be a good doer, but let's say that good doer can't do their good job, their good duty because of stressful life events. And it could be a private addiction that they're having, they're struggling with, or it could be an affair or something that they've done that they feel ashamed of. And they're already a high level risk taker, but a level risk taker by itself doesn't make you suicidal. But if you've got a client who's in a high risk job per se, and they're a risk taking individual, they don't mind pushing the limits, right? That is something to pay attention to, in addition to the sad appraisal that they have about what's going on in their life. And the very third one, no surprise, is access to lethal means. So when these three elements, sad appraisal, lower moral conscience, this does not mean that somebody's a good person or a bad person. This is just that consciousness and accountability, kind of what I was talking about earlier, that concept that, again, not the stereotype, but the idea that African American, older African American, well, like the idea of doing good is deeply ingrained in their cultural ideology and their teaching and religiousness. So those elements become protective factors of doing good. I could never do that to hurt anyone else, right? So when you see that loss of kind of consciousness go away, then there's a more of a danger. And then, of course, if they have an available method, and this does go into the hanging, into the poison, the overdosing, and Also their level of mortality knowledge. If you know that this poison is deadly, if you know that this gun is deadly and I have access to it, like we do have a problem in the US that we have a high rate of veteran death and military death by suicide. Most of them have access to a weapon and they know how to use it. So that alone, they are risk takers, right? And maybe they're dealing with consciousness. They feel guilty. They have a sad appraisal. So when you're seeing these three elements begin to compound together, those are the things, if I were to simplify it, pay attention to your clients. And again, the one thing that most is controllable is the access to lethal mean. So we need to lead more heavily into access to lethal means because stressful events and awareness of doing good, those things can be culturally bound, and you're working with them in therapy to develop resilience and to get through stressful life. But if you can remove the lethal mean and delay it away through that adversity, you're less likely to end up in a suicidal crisis because it's just harder. You have to make help easier and access to lethal means harder. And it's almost becomes that simple in reducing the likelihood of suicide. So if you make it easier to get help, harder to get access to a lethal mean, then your chances of having a suicidal crisis diminish greatly. Okay. So that's the message that I want to score mostly with this group is that these elements coming together put someone into a suicidal crisis. Our job is to create a sense of hope by taking them through resilience, by helping them connect to a purpose, okay, by doing good, giving back to others, getting into recovery supports. That is developing their protective factors, right? So don't think that protective factors are fixed. You want to add more in and remove, again, that very last one in particular, the access to lethal means. More than half of people who die by suicide had access to a lethal mean. And I'll just tell you, my sister, her own case. Her former husband was a police officer. She used to have a weapon. And I remember talking to her and I would say, you know what, you should get rid of that gun because she was so mad about going to a divorce. She was so mad about getting her license suspended that I got the gun away from her, but she went through a divorce and she ended up staying with somebody who had a gun in the home that was unsecured. It wasn't even her gun. It's not like she went out and got it. She was just staying with a person who kept a gun in the house and she had access to it in her bedroom, and that ended her life. And her daughter was in the next room. So, in that desperation, the ease of access, and this is before 988 came out. And I was like, man, if she could have just remembered that 1-800 number, but who remembers that? Now 988 is easy. So encourage people to use that. I have clients that are high risk. I make it an assignment for some clients to just call 988 as a project. I'll say, call 988 and tell me how it goes. Because I just want them to get used to the exercise of when they're going through stuff. They can also call 988. And then I'll follow up the next appointment. Hey, how'd that call though? Did you call them yet? I've had clients who've used it to help other friends. Sometimes they just call to talk to somebody. So have your clients call 988 and break that stigma that somehow the police are going to come running through your home because you called 988. Just have them try it out. For some people are actually, I've talked to people who are like, I'm afraid of calling 988. And I'm like, dude, they're so nice. I know 988 operators. They're great. Right. Now, mind you, sometimes they'll come back to me and say, hey, it really sucked, or they weren't that nice. And so we get the process through. I was like, okay, we'll try it again. So use that as an opportunity to educate your clients and just try it. So let's see, how are we doing on time? Because I want to make sure I get to any more questions that you guys might have. Okay, somebody asked a question, would you recommend referral to psychiatry for anyone with a risk for suicide or for those with a current high risk? Hard to say on this one, but I will tell you this. When I was director of a psychiatric hospital, there were some times if this is a first admission into the psychiatric hospital and I don't feel like I can keep the person safe at home, great. I'm so glad you gave the number. I would, like parents, they say, put my kid in the hospital because they were stressed out, they were afraid. And we would work out a plan. I said, don't put your kid in the hospital. I said, you're going to start them off on the wrong foot and you're going to have them around other very high risk kids. So, what can we do at home to keep everything safe to get through this? And we'll have a follow-up appointment tomorrow because you putting them in the hospital for the next 5 days is not going to cure the suicidality. In fact, it could reset, make it go higher and they have more stigma. Psychiatric hospital have a higher risk psychiatric hospital at one point in time. Again, it's not, I'm sorry, my internet. Come on back. Okay. So those are important to keep in mind. Anyone with a risk for suicide or just for those with current high risk. And when you say psychiatry for anyone with a risk for suicide or just those with current high risk, psychiatry, I don't know if you mean a psychiatrist or if you need a medication, a psychiatrist is great, but they're not going to work on the therapy. They're just going to give the person a medication. If you're looking, oh, a psychiatrist. If you feel, if they're diagnostically, if they are dealing with depression, I've had some clients that I've seen that I will recommend them see a psychiatrist because I think the course of your either depression or anxiety as we're working in therapy is not is not it's not enough. We need this may be actually a brain chemical issue, and we need all the resources we possibly can. So I have a few clients I'm working with right now who I meet with every week, and every week I do CSSRS and I do the PHQ-9 to help them see the progress if the medication is making a difference or not. So my recommendation is yes, if they're not on any medication and you're looking for medication management to include in your therapy. It will not take the place of therapy, right? It's just going to deal with the chemicals in the brain. And there's other things that we're integrating, even our rehab centers that we're helping people with addiction. Anyways, I won't go into all that. But my answer to you is yes, if you're seeing the ongoing symptoms for depression or severe anxiety, if their GAD-7, let's say, is like above, or their GAD-7 is 20 and their PHQ-9 is 20, and you've seen that, then I'd say, yeah, and it's not situationally bound, meaning there's not something that has went on in their life that they can pin it to. I don't know why I feel this way. Okay, let's talk about an antidepressant. Let's talk about some kind of medication at that point. So, anyways, the safety steps that you can, thank you for your questions, by the way. I don't want to, I'm hurrying along because I'm mindful of our time. I'm about to the end and we'll put back in the resources. Let me see here. Renee, let me see if I can also send you. Oh, yeah. Okay. So I'm going to give you this one copy. Okay. There's another training I'm going to give to everybody too at the end of this. How long will the material, Renee, that might be a question for you. How long will the material be available on the dashboard?
So I made all of the material and the dashboard available for a long time. Rewatch the videos and share it with your teams. The only thing that's only going to be available for a day is the slides. But then Marlon said he would take things out from the slides and then we'll put a version up for you that you can also download.
Yep. Great. Thank you. So yeah, these are the safety steps that I want to just reemphasize with folks. Please use the death wish just to help with your warning signs, teaching your teams about looking at mood and behavior. See if you're using the CSSRIs or a version of it, great. If you don't have a firearm screaming or it's not pronounced enough, please use it. I believe strongly that's the one thing that we can do is just having a conversation about a firearm. And I've had a client who was suicidal. She had an attempt on a bridge. She had an attempt. And then I stopped one day and I said, you know what? Do you have a firearm? And she was like, I don't. And she said, you know what? Thank you for asking, though. And all of a sudden, we had this conversation that she just appreciated that now we were talking about this because she saw how important she was to me in that conversation, even though it had happened maybe 10 years ago when he had this history of attempt, if you will. And I asked her about even this with clinicians, said, how would you have felt if you were asked about firearm years ago? She said, oh my gosh, I wish somebody would have asked me about that years ago, at least when it felt like somebody cared about me. So it's an obvious conversation to have. And so if you're not doing it and having a dialogue with firearms, if it's there, if there's thoughts of using it, is it safe? If you've got somebody with these signs, meaning they have warning signs and of any kind, just make it your clinical intake form. Everybody's doing the PHQ-9 and GAD-7. Everybody should be asked about a firearm access. Okay, especially in the US. Okay. So again, and think about that for New Zealand too. Like, what are you seeing as lethal means? If it is poison, then ask about the poisons. Having access to those things. Make it very deliberate. For some reason, I don't know why. I think it's because, actually, I do know why, because people have been worried about don't say how somebody died. right, when there's a death. But the problem is we don't internally talk about it as a profession, and nor do we screen for it either. And I think it's because we don't know what to do with it. So have a plan of if a client says, yes, I have a firearm in the home, then okay, let's talk about how do we get it? How do we do safe storage of it, et cetera? Who else can move it out of the home? I've had this conversation with a good colleague of mine, and he didn't want me to tell anybody, and he was mad about me. But guess what? He's still alive, and he thanks me now for having that conversation and intervention with him. And good, suicidal, self-harm, and protective factors and triage. Excellent. And ask about firearms. You have access to firearms. Just make it a general question. We're not going to come for your gun or anything like that. And people need to understand that too. Oh, this is not going against somebody's right to bear arms. We're just asking, do you have one? And is it safe? Not just protecting you, but the people around you, kids in the home, because I've seen it happen. The father of my great niece had guns around, and they live in Ohio. And yeah, and I was bothered to see like a video when I was going back through, like he was like carrying the gun around. And I'm like, boy, oh boy, that's just such an obvious conversation to have. And I didn't have a close relationship with him. I met him a few times, but him and my niece had their kind of spats or whatnot. Obviously, she's struggling with it. So, anyways, I just want to employ like, man, somebody just asked him and say, hey, maybe you shouldn't have those guns around, but people love their guns. You must have a gun safe. This is great. So this is an example in New Zealand that you have to have a gun safe in order to have a firearm license. I also ask the clients have understood of gun safety, even if clients rate no or low risk and top of gun safety questioning. Excellent. These is great. Any other tips that you guys do, please put them in there because people are reading them. So we got people from all over states and New Zealand. I appreciate you being here too, because this is how we get better is we have conversation on what we're doing and best practices to figure this out. The other thing, oh yeah, the other thing that I'm going to share with you is, which is also an important part, is postvention. So this, Renee, if you could also share, I'm sending you also a sample of a postvention suicide policy. If you do not have one, every organization should have a postvention policy because it helps you know what to do. This is an example that I developed and have implemented versions of it. So it walks you through. Postvention is prevention. After a suicide has happened, people freeze and they don't know what to do. And we always talk about this notion that there's a contagion effect of suicide. And yes, there's evidence that's the case. So when a suicide happens, it's a traumatic event to you as a provider, to the institution, to the employees, to the patients, if there were patients around. So having this in place is the best place to start when you're developing your prevention plan. Is if it does happen, because I just told you the frequency, it's the second leading cause of death of people ages 10 to 34. There should be a postvention step practice in place to, just in case it were to happen, you know what to do. It's like your emergency plan, right? Or if we are required in these institutions to have evacuation plans, right? Just in case there's a tornado, there's a fire. If there's an active shooter, think about what's my postvention policy. And I outline you steps that you could take, that you can modify, who does what and when. And you should, if you're doing annual trainings with your staff, you should have an annual training around your postvention policy. Lord forbid you have to use it, but it's the same thing. If there's a fire in your house, God forbid you have a fire at your home. But if you don't know what your exit route is, if you don't know where the fire extinguisher is and how to use it, and you haven't practiced it, then you're not going to know how to deal with it. And that includes your leadership. So supporting your staff, responding to the community, helping other patients, providing supportive resources, having debriefing, and then doing a clinical autopsy of what happened. What could have we improved to it? Was it a firearm issue? Was it we didn't do a safety plan? What could we do better? And it's not about blaming, it's about honoring the life of the individual to take enough time to see what could have been done differently. This is, for me, what I am doing in response to the suicides by gun that has impacted my family is giving resources, talking to other providers. I am open to share whatever resource I possibly can. And I want to encourage other providers to do the same thing based on what we're seeing. And I'm based on my now lived experiences with suicide, which were both devastating. And thank you again for your condolences. So the call to action is this, is simply to screen all your patients with firearm questions. Always. Renee, feel free to, if you did not capture it, again, it's on the dashboard, but the firearm, pull it down, download it, take a look at it. Complete a postvention policy. These are the things I want you to do. Postvention policy. Have one for your organization or for your practice. What would you do in the case of? Okay. Train others using Death Wish. Just getting familiar with the warning signs allows us to begin to have the conversation. So I'm sharing that with you today too, the policy, or excuse me, the Death Wish warning signs. 988 as a resource. Use it often. Just use it. It's free, it's confidential, get people comfortable with it. And then lastly is the CALM training. If you want more training on access to lethal means, and this applies to any type of lethal means, it's free. You can get more CEUs. I just dropped the link into our chat. Click on it, save it, take it at your leisure. It gives you a certificate. I had all of my therapists and case managers do this at a hospital I was working with because it was free and it was very well done. So it walks you through all of the details of counseling on access to lethal means. I ask you to remember my niece, my great niece, Amelia Rose. This is actually a picture of her. Isn't she adorable? She is. Give me a little heart if you like my niece. Yay. It makes me feel good. She's wonderful. But this is the day of her father's funeral. Okay. This is the day after Father's Day. And so her name's Amelia Rose. And I don't want her, this is the notion of, okay, you raised hands. Okay, so thank you so much. She is beautiful. Lily, you raised your hand. If you have a question, what are your thoughts about hospitalization when it creates additional challenges to the patient, medical debt, loss of income, more stigma, to assess those impact of those factors? I can have it definitely. My thought is like if you can avoid it and keeping them out of the hospital is your best way to go. But if you can't keep someone safe in the community and hospitalization is your last option, then use it. But you should be aware of the risks that you're taking because some people don't think about that going into the psychiatric hospital, that you're going to add potential risk to that individual. But if you cannot keep them safe, that literally that they're a danger to themselves or others, or they've had a recent attempt, I'd say do it and work with them closely, especially when they get out of the hospital, because it's not a death sentence. I also know I had a client one time who was in the psychiatric hospital in Indiana, and then I was doing a training in Orange County, and he was like, "Dude, I was in your hospital," and he's sitting in the room doing a suicide prevention training with me, and he was, "It wasn't for that treatment." So it's not like it's going to, in somewhat, a lot of people are saved through psychiatric inpatient treatment when it's needed. So it's there. You can keep someone safe in a psychiatric hospital that's ran well. You should know the risks, and it's not we have to work better on the stigma that we still have around psychiatric hospitalization, that's for sure. So ideally you can get the person to go voluntarily. That's the best way to go. My sister did go voluntarily into a psychiatric hospital, but it wasn't until, and it actually saved her at that time, but she was in an outpatient program that was not screening her for suicide, nor were they asking her about access to firearms because I read all her paperwork. They were not looking at her clinical documentation because she was writing about not feeling like she was worthy of living anymore. And so I saw her 5 days before she died and she was very depressed, but she was in treatment and I was trusting that treatment center to look after her, and it didn't happen. So that was my call to action, to be in a place to do something more. And that's why I've played the role of CEO and COO for a number of years. But to help institutions provide better care. So this is my resource. You can follow me on IG at Dr. Marlon Rollins. Again, and that's going to conclude the presentation today.